So I will start my talk on the fractured neck of femur in different patients and different options. When any orthopedic surgeon faces a fractured neck of femur, our reactions can be quite different. And in fact, our reactions to this particularly challenging fracture is always linked with the possible complications with avascular necrosis, with non-union and so on. And we tend to ignore the demanding issue of this fracture about our technique. And it's not only about AVN and non-union that we can end up with results that are far from being satisfactory like this case. So the mainly intended learning outcome from this talk is not just to talk a lot about the different patterns of fractures and what type of fractures we face and the avascular necrosis and so on. But I think if there is one main learning outcome is that we have to remember that our choice of treatment and the timing of implementation of that choice of treatment may play the main role about the outcome. And we have to remember that the same type of fracture occurring in different categories of patients can have different results. And the same type of patient can behave differently depending on the different type of fracture. We were brought up as surgeons to believe that there are two main categories of patients. The young with the high energy trauma, the better bone quality, where fixation is usually the main issue and the main type of treatment. Conversely, there is the old patients with osteoporosis, with a low energy trauma, where arthroplasty is the main choice. And in fact, this dichotomy of classification is the one for which we made two webinars, one for the old and one for the young. But I tend to believe, and many of the surgeons know, that there is this entity of patients that I tend to call the older than the young. These are the ones which have some of the characteristics of the young active. They can still be exposed to a higher energy of trauma. The osteoporosis may not be that profound. And internal fixation is still a very useful and viable option with only the arthroplasty at the back of our mind. I do not underestimate the risks involved with avascular necrosis and non-union, but I stress on the fact that the implementation of the treatment and the technique, how much of that can influence the result. So to me, such a result is probably influenced more by the treatment than by the abysmal natural history of a femoral neck fracture. What I also observed is that we do not have too many classifications for the femoral neck fractures, and perhaps we should have had more. The main difference in most of the classification is that there are the undisplaced fractures and the displaced fractures. And when you look at the very popular Garden classification, you'll find it a classification with not a very satisfactory intra-observer and inter-observer reliability. And in fact, the Powell classification has merely the benefits of pointing our attention to the risk of secondary displacement with a vertical pattern of fracture. The rest of the classifications to me are too cumbersome for me to remember, and I don't think that they will give us a very significant insight into a choice of treatment. So how important is the femoral neck fracture? It is extremely important. I think that 1 in 5 of any orthopedic surgical intervention all over the world is probably related to some injury around the hip. And 50% of these are intracapsular, so it's a femoral neck fracture proper. And there is a very high lifetime risk for the females. I think 1 in 2 females will probably have to face the risk of a femoral neck fracture, of which 80% or more are displaced. 15% are displaced. The classical patient is starting from the age of 65 and above or 70. And thank God we are bipedal patients, so the risk is only doubled, one hip to be fractured after the second. If we had more hips, we would have probably had more fractures. The other thing that we observe is that we as human beings, the sapiens people, could somebody stop the One mic has to go down, please. Thank you. So basically, as organisms that tend to turn into jellyfish as we get older with loss of bone mass, the osteoporosis plays a very important risk for femoral neck fractures. Not only it increases the risk of femoral neck fractures, but also it tends to cause a very low energy trauma, provoking a comminution, a displacement at sites more common than other sites, and a bone density that doesn't allow our fixation device to get a good purchase into this bone area. And it's true that some of our patients may have better cognitive functions and better musculoskeletal control, but most of our patients of that age group have a higher risk of falls. And in fact, one report from the NHS has stated that every 18 seconds, one elderly patient will be wheeled into the emergency room as a result of a fall, of which a big proportion may suffer from a femoral neck fracture. The classic patient tends to fall on their side with a bit of an external rotation mechanism of injury that causes comminution of the posterior neck. And the main site of bone loss, which is the proximal part of the femur, is usually the commonest site of fracture in a body that has other systems that tend to fail, increasing the anesthetic risk for this patient for surgical intervention. So this is the classic patient with a good percentage with cognitive impairment, but that should not reduce their right into having the best possible surgical treatment to help them through a very critical phase of their life. The literature has shown us without doubt that after 72 hours of delay of intervention in a femoral neck fracture, the 30-day mortality increases significantly. And a recent paper in 2020 has shown that that risk can increase starting after 24 hours of delay of surgical intervention. Nevertheless, the undisplaced femoral neck fracture have shown a propensity to have a good result with internal fixation. In fact, the incidence of non-union and avascular necrosis is very low in undisplaced femoral neck fracture. And this has encouraged surgeons to choose internal fixation irrespective of the age of the patient. But with a displaced femoral neck fracture, arthroplasty is definitely the choice. And we will have a very interesting lecture by my good friend, Dr. Ayman Abeid, about the choice of prosthesis and arthroplasty. Still, quickly, the hemiarthroplasty has been one particular choice for the femoral neck fracture, with an alleged advantage of less dislocation due to a large femoral head. But I think nowadays we will hear about the benefits of dual mobility that has superseded the hemiarthroplasty. Whether a unipolar hemiarthroplasty, which has a satisfactory result, or a bipolar hemiarthroplasty with a slightly better result, both of them tended to work historically fairly well. Obviously, there are indications for total hip arthroplasty. I would say the top of the list is an associated arthritic hip. A rheumatoid patient like this doctor, who should have probably had a primary total hip replacement for a femoral neck fracture instead of needing to go into a much more major reconstructive procedure due to failure of a unipolar hemiarthroplasty. Again, the failure with the decrease in bone mass dictates the use of a total hip arthroplasty. But finally, we are particularly getting more and more interested in using total hips, which we will hear about with Dr. Ayman Abeid, for the active patients, like this one in their mid-60s, and this one in his mid-70s. I would still go for a total replacement for somebody who practices sports, running and jogging every day. So why not reduction fixation for this age group? We are particularly concerned about a much lower incidence of union in the elderly patient with a higher incidence of failure of fixation due to the reduction in the bone mass and the bone stock. We know that the reduction in internal fixation for the elderly with displaced femoral neck fracture, much higher incidence of non-union. Added to this, the incidence of avascular necrosis, this produces a much higher incidence of revision surgery when we choose internal fixation for the elderly patients. By contrast, the lower incidence of revision surgery encourages surgeon to use an arthroplasty, especially a total hip arthroplasty. Surprisingly, there is no really difference between the different mortality rates, whether you use an internal fixation, a hemi, or a total hip. Surprisingly, the total hip replacement in randomized controlled trials have had a much better rate turning mortality. This is probably a bias in sampling because we tend to use total hip for the younger, active, and healthier. So whether we use a hemi, internal fixation, or a hip replacement, we know that the best functional result is obtained with a higher Harris hip score when we use a total hip arthroplasty. But a successful internal fixation would probably supersede a hemi-arthroplasty hip score. So what is internal fixation in this particular group from 50 to 60 or 65? So this is a younger patient, and I'm just using this example to know what we should do with internal fixation. The teaching have shown us that the best way to deal with these fractures when they are displayed is to obtain, first of all, a closed anatomical reduction. Fixation, the most common device, is with 3 cannulated screws. They have to be put in a specific pattern, an inverted triangular pattern, with stress on the most inferior screw and the most posterior screw to support the posterior cortex of the femoral neck. The screws have to go as far as very close to the joint to get a good purchase within the femoral head. With that, slight collapse invariably tends to happen. So a little bit of pulling, which is a controlled pulling of the head of the screw, does not mean failure. In fact, it means that we are aiming for union. Most of the femoral fractures which tend to be fixed can show some element of pulling the screws, which is a good sign denoting union. And with union, results are supposed to be satisfactory. The older active patients have to be given the same chances and the same technique as the younger active patients. They have a better bone quality. They still can have their share of vertical fractures, and fixation is the primary choice. Arthroplasty should only be put at the back of our minds. So this is a 59-year-old active businessman, and we had a talk and a discussion about internal fixation versus arthroplasty. We opted for internal fixation. The same procedure. We have to try as much as possible to get a perfectly anatomical reduction in both AP and lateral views. I stress the value of the posterior screw, which has to go supporting the posterior cortex to avoid secondary displacement, as well as the inferior screw in the pattern that we know. A little bit of pulling due to collapse at the femoral neck will show that the femoral neck is actually going into union. And with this normal natural history, we end up with a good, satisfactory result of the patient. So remember, we have to follow the guidelines. Same types of implants, the same number of screws, same configuration, and same positions as we did the young active patients. Rarely one uses 4 screws. We tend to use mostly 3 screws with special emphasis on the posterior screw and the inferior screw. These are the main supportive screws to avoid failure as a result of a posterior and posterior-inferior comminution that tends to happen with most of these fractures. This is a patient in his 65 years of age. He's again another active patient. And following this discussion about the options of arthroplasty versus internal fixation, we opted for internal fixation. So a closed anatomical reduction is chosen. The screws are put in their strategic positions. I always tend to strive on obtaining this posterior screw really abutting on the posterior cortex to support it and prevent secondary displacement. Very slight pulling out of the screws, slight collapse in the neck, in the fracture plane, which ends up with union of the fracture. This is an orthopedic surgeon, my colleagues, and in his early 50s, he suffered from this injury. It's a Garden 4 fracture. And again, we opted for internal fixation. the same technique, close reduction. Anatomical reduction is of paramount importance. You can observe the comminution on the xeroscopy viewing. The screws are put strategically. The posterior screw is very important to support the posterior cortex. And the result goes on to be satisfactory. There is an element of collapse, but still the fracture heals, and he's been fully weight bearing, back to his normal activity for the past 4 years. This lady in her late 40s, I'm bringing her for a specific thing, this significantly displaced Garden 4 fracture. Again, we go for the internal fixation, always trying to strive to obtain an anatomical reduction as much as possible. If we end up with a slight valgus, this is better accepted than a varus, but obviously the anatomical reduction is the first choice. Then we end up with union. What is interesting about her is that she goes on, as we mostly expect, or we mostly fear, to go with avascular necrosis. She has a sector of avascular necrosis, which is superlateral. Surprisingly, but then this is something that we've seen in many of my patients, avascular necrosis is much more tolerated following femoral neck fracture than avascular necrosis due to an idiopathic or steroid-induced. So even with avascular necrosis, she went on for several years with a good functioning that she can, without needing to change that into arthroplasty. So if you look at any classic recent textbook, they will tell you that an undisplaced fracture is preferably done with fixation. Once you go into displaced fracture, it depends on the age group. A cutoff number of 60 is chosen, whereby above the 60, they will tell you arthroplasty is the choice. We will hear that from Dr. Ayman Abeid. But below the age of 60, in the absence of any significant osteoporosis and poor quality, you will choose reduction and fixation. Above that age, then you can start to tip the balance towards arthroplasty. My observation is that nowadays we should revise this cutoff number. I think perhaps we should raise it. Is it 65? Is it less than 65? More than 65? I don't think the number really counts. The issue is the activity of the patient and the bone quality. A good bone quality with an active patient can ask for an internal fixation with the possibility of a good functional result. So I end up with reminding you that although avascular necrosis and non-union are two particularly pointed at alibis for having bad results, the surgical technique is the one that can influence your results much more than this alleged natural history of femoral neck fracture. And if you follow the technique well, you're bound to end with a much better result. Now, this is a fracture that demands very careful study. There are different type of fractures and different type of patients. And it is true that most of us as surgeons, we study our fractures carefully to assess the placement, the classification type, the best way of fixation. But I think we should add something else. Besides studying our fractures, we also need to study our patients. Thank you very much.